This
here.
conference will now be recorded.
So you can still see community of practice?
Yes, Jeff, it's on there.
Good. All right. Well, so we're going to start going through the slides real quickly. This is Jeffrey Popkin, and today's presentation is going to be on home and community-based waiver. If you want continuing education credit for this class, you must attend the entire class. You must identify yourself at the beginning of the presentation, either on the internet or by sending something in the chat letting us know that you're on. If more than one person from your site is on this, you need to identify each person that's going to be taking the class. At the end of the class, you need to send to Irene at Bakersfield ARC 3 items that you learned from today, so that we can make sure that you did attend and listened carefully to the presentation. And we ask that you do that within 30 days so that we can keep our records current. Bakersfield ARC has available a self-paced 31 modular HCBS training through a company called Relayus, and these are modules that you can take on your own time. You can start one, leave, come back later, finish it up. Then if you take the quiz and get a 80% right on the quiz, you can then submit for continuing education credit for those courses as well. So it's another way to get credit for things that are necessary for Department of Social Services and for regional centers. So if you're interested, get a hold of either Valerie or Irene, who are both on the screen there. Well, they're both over at ARC, and they can get you set up. It's first come, first serve. That will be ending at the end of September. So if you are interested in getting involved with this part of the grant, that is time limited. And coming in July and August, we have 2 systems experts from the East Coast coming out to California to do training on issues related to vocational options for individuals. And they're going to be half-day presentations. There's going to be some set up specifically for programs that provide adult day services. There are also going to be some that provide vocational services. And for those providers that provide both adult day and vocational, you can go to both, or send some of the staff to one, send the other staff to the other. It is free, and it is, like I say, these are experts who are systems matter experts with the U.S. Department of Labor. So they're top-notch people we're bringing out for that. This is the brochure. This particular brochure is for the community-based day services. But if you look at the QR code that's on the screen and capture that, that will take you to the application for either the adult day or residential. So if you are interested, just capture that QR code and go from there. Okay, today we're going to talk a bit about the home and community-based services, HCBS. I always think of like CBS as being a TV network, but in this case, it's not. It was originally designed to provide care and support to individuals who would otherwise need to be in a nursing home or hospital. It came out of a case in 1981 called there was a young woman by the name of Katie Beckett who suffered a pretty serious situation and was on a ventilator and needed a great deal of care. And the parents wanted to bring her home, but at that time the regulations were that she could be on Medicaid if she was institutional setting. But if she was at home, the family would lose the ability to get supplemental help for her care, the care that she needed, because she needed it 24 hours a day. Mom wrote to at that time President Reagan and shared she didn't think that really was in people's best interest to not have the availability of these services at home. The president agreed. He started a waiver program to do that. Initially, it was with kids. It eventually morphed into a larger organization of all clients who were eligible for Medicaid who had at minimum two significant deficits in their daily living skills, their personal hygiene, etc. And today it is a large program. When it first started out, there were more people in institutional settings than there were in community-based settings. Today, it's just the opposite. There are more people in community settings than there are in institutions. So we are now looking at, so for example, in California, we had in the late 70s close to 12,000 people in our, at that time they were called state hospitals, subsequently developmental centers. And today there are about 400 at Porterville who are there because of situations with criminality, breaking the law and being placed there rather than in a prison situation. And there are a couple of state-run operated facilities for specialized needs, but for the most part, there are no state hospitals anymore, other than the one program up at Porterville. The whole idea behind it was to promote independence and to maintain people's connections with their families and friends. If you were a family living in Bakersfield and your son or daughter was up at Porterville, that was an hour plus drive to get up to see your son or daughter and stuff. Subsequent to the Medicaid waiver, which predates the home and community-based waiver. We'll talk a little bit about that later. There was a couple of things that are really important to this whole community-based movement. One of them was the Olmstead decision, which was a Supreme Court decision, which said that you can't use just funding alone to make decisions about where people live. So that if somebody is appropriate to be living in the community, you have to make the arrangements for that person to be able to live in the community. Major decision in terms of community living. The other one was the ARC California versus DDS, which was a case that really established the entitlement in California. That case, the court said if it was the intent of the legislature that services flow from the IPP. So whatever gets written in the IPP, the person receives consistent with the Lanterman Act. And that really moved the purchase of services and supports forward in California, whereas before they were somewhat restricted. The HCBS final rules were adopted in March of 2014. These went to basically public comment before they came out in the final stage. They were sent out to the community. Anybody who was interested got notification, had an opportunity to provide feedback. Based off that feedback, they came out with the final rules. They ensure that California, by receiving federal Medicaid funding, which here in California is Medi-Cal, meets the needs of individuals who choose to receive their long-term services and supports in their home, residential settings, and communities rather than institutions. So if someone makes the choice that they listen, I'd rather be in the community and receive my services here, then this is a program. So it is a voluntary program. So people can elect not to be on the waiver program. Because that doesn't necessarily mean they're going to live in an institution, but to receive waiver services, folks have to actually sign a form with some regularity. The regional center service coordinator brings it out saying that they want to be part of this program. Persons served under the waiver have full access to benefits of community living and opportunity to receive services in the most integrated setting appropriate. California, along with every other state, has submitted to the federal government the type of services that they want under their waiver. And the federal government has approved California's plan. And based off of that plan, those are the services that people receive here in California. Enhance the quality of services and provide safeguards to participants. So the whole idea behind it was to make it so that the quality of services is better. I go back to the old days where we sometimes would joke that we were providing people, 3 meals a day and a bed, basically, and that was what services were all about, and nothing about programming, nothing about promoting independence, nothing about developing community, and that's all changed. Also, under safeguards, right to privacy, right to dignity, freedom from coercion or restraint are all part of safeguarding the participants. Service planning must be developed through a person-centered process that addresses health and long-term services and supports needed in a manner that reflects the individual's preference or goals. So when the feds say service planning process here in California, we're talking about the individual program plan. And when it talks about reflects individual preferences or goal, we say person centered. So that means it's based off of what the person wants. Years ago, an IPP would be where the team sat down and the provider of service would say, okay, this is what we're going to do for the individual for the next year. Regional center would say, okay, that's good. That's a good plan for him and or her. And that would be the team meeting. And very little of any feedback from the individual themselves would be involved in making those decisions. Now, one of the things that HCBS does, and we usually talk about it from the perspective of you as a service provider, but there is a requirement for case management in HCBS. And that is a crucial service that helps individuals with IDD and their families navigate and access the necessary support system. The goal is to ensure that individuals with IDD can live independently as possible within their communities. Again, community rather than institution. Personal supports. Case managers work closely with individuals and their families to create personal care plans that address the unique needs and goals. So that's the yearly meeting where you sit down and develop the IPP. In California, over the years, the legislature has developed standards for caseloads and based off of the needs of the individual. So, for adult clients living in residential, it's usually 1 to 62, 1 to 65. People living in the community, adults again, 1 to 65. So that's currently what those ratios are. Different regional centers are meeting those, some are not. Every year, the state requires regional centers to have a public meeting and to talk about whether they're meeting their caseload ratio or not. Those that are not get put under a corrective plan by the state, and to help them to make sure that there are enough case managers, service coordinators to provide all the ability to write the plans, to monitor the plans, to really address quality issues in service. Coordination of services, they help to make sure that the individual is getting all the services they need. Now, not all the services that a person needs come from purchase of service. There are other sources out there in the community that can provide that. So sometimes that can be public education, it could be medical care, it could be therapy, could be employment support through maybe Department of Rehab or some other, and then also community recreation could also be there. So the coordinator is not just about writing a plan for what regional centers buying for clients. It's about the whole needs of that individual and all of the services. Advocacy, the coordinator is supposed to be an advocate for that person to make sure the rights and needs are assured. And if there is some problem, to maybe to help that person either self advocate to teach them how to do that on themselves, or to help them and plug them in to the resources that would get them the services and the due process rights that are afforded to them. Um, Again, monitoring evaluation, going out and making sure that if we have a plan that this state program is going to be providing this level of service, and this is the goal that we've set for the next year, where are we with that? And is that working? And is it effective? And do we need to make adjustments? And then if there is family, we want to make sure that that family involvement with the permission of the individual, because it's the individual's holds the privilege, but if they so choose to have their family involved in the process, the coordinator can really work on developing that family plan. Um, Enhanced person-centered planning and community integration. The regional center and providers must ensure that every service plan, IPP, and then the ISP, the individual service plan that you write, is tailored to the individual's preferences and goals. So in the old days, we used to oftentimes call them cookie cutter plans, where one plan would get used over and over again, just like if you had the dough sitting there out on the countertop, you would sit there and cut out multiples of a cookie. That's kind of what IPPs look like. Client will attend a day program. Client will live in XYZ residential facility. Client will see the doctor yearly. So nothing technically individualized to that person. And the new HCBS rules, final rule, says no, we have to have an individual plan for each person, and that has to be based on their needs, wants, and preferences. And this isn't just a formality; it's in the law, and it requires the regional center. They went to that new IPP form that you're now seeing yearly, and some people have complained that it seems like it takes longer than the previous one did. Well, two reasons for that. One is first time around, so people are learning the form. But second of all, it asks more relevant situations and questions about what's going on with this person, and really trying to elicit from the individual themselves what they want from their lives. And again, the focus should be on community integration, consistent with the abilities of the individual. Now, different individuals, that integration can be different. I went out and was doing an evaluation last year, and there was a young man that was living in a residential facility who had a great deal of capability to use the community. And while we were doing the evaluation, he says, "Well, I'm going to go now." And "Where are you going?" And he says, "Well, there's a pickup game that I get involved with, every Wednesday at the park. We play basketball." So he was like able to. For him, that was community integration. His plan reflected that he would be independently utilizing the local parks and recreation. Um, Okay, so the underlying goals of what is HCBS trying to accomplish, really? As we mentioned earlier, enhance quality of life, allowing individuals to receive care in their own homes and communities, promote independence and a higher quality of life. Years ago, they did some studies where they called them movers and stayers. And the movers were people who moved out of the state developmental centers here in California. And the stayers are the people who are still residing there. And using a quality of life assessment, a tool that was geared towards figuring out what somebody is, how happy they were, and how how involved they were, they found that the people who had moved out of the institutional settings, the developmental centers, overwhelmingly were more happy, more secure, more felt like they were receiving better services than those folks that were still residing at the institutions. Um, Personal care services are tailored to the specific needs of the individual. Um, and our system is now aging. Because we've done such a good job in providing for people and addressing healthcare needs, social needs, and other things. We're seeing a larger population of senior adults. In the past, there weren't a lot of developmentally disabled people that made it into senior years. Now we're seeing more and more of that. And so that's one of the areas. And that comes with a unique set of needs in many cases in terms of personalized care and integration in the community. That's different than someone who, like this young man that I was talking about a minute ago, who was our basketball player. Um, so, and we also want to think about personal care for people who have chronic conditions. You're again going back to when we first were looking at moving people out of the developmental centers. People would say, "Yeah, Mary over there, she's fairly uh, capable, and she could, in theory, live in the community with some good assistance. But we have Sam over here, and he has some chronic medical conditions, and he's not going to be able to leave the development center." And that was sort of we heard that for a while. And, as more resources became developed, more specialized group homes, more specialized day services, technical supports, etc., we started finding that we could even move those persons who had chronic medical challenges, provided that we developed a specific environment that could meet the needs of that individual. Towards the end of the regular units on Porterville, before it became just a forensic facility, uh, it was getting to the point where it was costing over $300,000 a person, just because you had certain fixed costs. You had the cost of running the institution, and as you had fewer and fewer people, that cost became greater per person. And so, from a cost-effective standpoint, home and community-based services reduces healthcare expenses. So we find that people are happier. It's less expensive. We can provide personalized care, and then finally, community integration, helping people connect with their communities, fostering social interaction and support networks. So we're really helping people to become part of their community. Now, environments. All physical environments and care routines must promote community living rather than mimic an institutional setting. So, I remember the first time I went up to Porterville and walked onto a unit, and in the off of the entrance, there was a nursing station, and to my right were a set of beds. On the one side, was the female part of the unit, and on the left side were a series of maybe 20 beds that were the male side of the unit. And it was all one big, two big rooms, where everybody lived. Over the years, they did quite a bit about putting up partitions and individualizing space for people. But that's part of what we want to make sure that we're not mimicking a setting that looks like a hospital, a nursing home, a state institution. Uh, and so the rules really encourage modifying environments so that people have more community life and opportunities for employment, social interaction, independent living. I mean, one of the things that we found with group homes, which was somewhat of a challenge as we move forward with these new regulations, is the whole area of that individuals should have a lock to their room. That some people were, felt, well, no, we can't really do that. What if we need to get into the room? Well, you can knock, and and you can have a key for emergencies. But really, it's that individual's personal space. They should have the right to their privacy. Um, and hopefully they do in most cases now. I went out to one home, kind of a funny story, and the an individual proudly came up to me and said, "Here, I have my key," and he pointed his key and showed me, and he said, "Yeah, and this key fits every other bedroom as well." And so the provider had sort of heard what we had said, but didn't really get the concept correct. And so we had to go back and have them rekey the other bedrooms so that not everybody had the same key. In many instances, providers have updated facility characteristics. So they've changed the way it looks. They've looked at some health and safety issues that were involved and done things to make it so that it's more community-like, more home-like. You know, over the years, last couple of years, we've had Dr. Pomerantz come out and speak, and he talks about how, like having the California employment rules on the refrigerator in the kitchen is not like a home type setting. On the other hand, you have to have posted those somewhere in the home. So, there are some trade-offs that we are constantly looking at when we're doing this work. Um, the let's see. Um, to implement the new service model effectively, providers are encouraged to invest in comprehensive uh, developmental DSP training. So, if you are a staff person and you're on this webinar today, great news. So you're doing it right. You're getting that education that you need towards meeting the requirements for this. If you're a provider, manager, or owner, I find that getting the information out to the people that are doing it so they know why this is important and why it's the law is really important. So you need to make that investment. I worked at Bakersfield ARC for a number of years, and we did a lot of training with our staff on hey, these are the new rules, this is what's coming down the pike, and everything else. And yet, when we first started doing some of that in regards to, you know, community-based day services, there was a little bit of resistance. People like the old, hey, look, we're here in a classroom, and we like being in this enclosed classroom. So there's change is always got some positives, some things that people are resistive to. Sometimes you change something and then find that that wasn't quite right. We need to go back to the drawing board and figure out a new, different way. But it's important that we really invest in our staff, our direct support professionals. Staff must be well versed in delivering person-centered care. So, are they doing things with the individuals they're serving that are reflective of what's written in their plan? Some people call it meaningful, services. I mean, are we just kind of working off the seat of our pants, or are we really doing focused on what it's all about? And then one of the other things that is going to become more and more important as we move forward, and especially next year as the state really starts looking at that 10% of your the fees that you receive from the state will be predicated on performance based, that your reporting and documenting is well done. And that's going to be my next training next week will be on reporting and documenting. So we start looking at what is going to be needed to meet these new rules for person-centered planning and what service plans should be looking like, etc. So stay tuned for that if you're interested. Help ensure that service delivery is consistent with the enhanced requirement and that staff are ready to support the community integration goals. So you want staff that are going to support community integration. There are folks that when we made the change at Bakersfield ARC, ended up leaving the organization because they didn't feel comfortable with it. Some of them went to work for other providers, or some of them left the field. But you need people who are really got the belief system that we're moving forward and our goals are to assist people in living greater independence with more community activity and more decision making. And my final slide today, we're going to end a little early today. Whoops, I got two more slides. Okay. Some of the challenges that HCBS brings is you've got to comply with these new regulations, these 10 regulations, and Regional Center will be out to your facility at some point to give you an evaluation. They've in the past, I've been hired on a couple of occasions to go out to facilities and do that for Regional Center, so that they or I or someone else will be doing those, where they're going to make sure that you are aligning with the federal regulations. But at the same time, just because you're doing the federal regulations, you still have to meet the California Code of Regulations, which are Title 17, which is Regional Center regulations, and Title 22, which is community care licensing. So, and there are a few places where they are not in total alignment. The community care licensing has gotten some training for their evaluators so that when they're out in the field and going to facilities and they see the newer plans for clients, they're looking at that carefully to make sure that that's consistent with what the facility is doing. So for folks where clients are like maybe going out in the community unsupervised or involved with other activities away from the facility, or utilizing the community, or in the home and have access to the kitchen, etc. Those situations are predicated on the plan. One of the other struggles that you all, in many cases, have is that there's a workforce shortage. There is a struggle in recruiting and retaining qualified DSPs, which can limit access to service. I was just reading an article recently where they did not in California, but in a few other states, where they did a poll of residential providers, and within the first 6 months, you have the highest turnover, and it still stays high at 6 to 9 months, then 12 months, and then it sort of tapers off. So if somebody stays in the field for a year or two, they're more likely to stay. But there are a lot of people who get into this field and leave it. Then the other issue you have with this is that now that the immigration policies have changed in this country, there are a number of people who work in this field who their legal status can be a challenge for them, or they have family members who have challenges to legal status, and that can affect their ability to work in your facility. And then there's funding and budgetary constraints. California is looking at a long-term budget challenge. They're talking about $12 billion for the fiscal year that starts July 1, and then the next at least 2 years they're projecting deficits. And we still haven't seen the full effects of the cuts at the federal level that the Trump administration is proposing and implementing. And so we don't know exactly where California stands, but the ability to provide rates that actually reflect your cost are somewhat of a challenge. And although we're going to this new or finalizing this new rate model, which in many cases has helped, but not in all cases, the rates are still artificially low. And we'll probably continue to do that for some time in the near future. Okay, and this is my last slide. The You're encouraged to do some self assessments. There are tools out there. The regional center has a tool. If you go on the DDS website, there are tools to look at your current operation against the federal rules and see, hey, am I really doing what I'm supposed to be doing, and doing a plan to help you make the changes or to improve what you're doing. And so a systematic review enables the creation of a phased transition plan with specific measurable goals. Any questions? Anna, I noticed you're on today. And you were actively involved with certifying people for waiver for many years. What do you think?
I think it's good progress.
Uh-huh.
Yeah, I think they've done a really good job in having people really look at lifestyle. I mean, I've been involved in the field for many years, and everything you've talked about, we've navigated through all of that. So it's going to be really important to follow through with all of the requirements so that we can get a really good picture of how much progress is being made.
Right. Uh-huh. Oh, thank you. I appreciate the feedback. How about you, Leslie? Anything you wanted to add today?
Thank you, Jeff, for your presentation. You highlighted a lot of the qualities that we're trying to continue to enhance. These areas are things that we're going to have to pay attention and continue to refine as we continue our services. I did kind of notice how you highlighted the workforce shortages, and I was talking with a few folks recently about how some of it can tie to confidence in our DSPs and how we could build on that confidence to really integrate a lot of these qualities. We've done so many trainings for our service providers um, that often the administrators, the lead, house managers, and program staff that attend, they often hear all this information, and how could we continue to support our DSPs now that maybe hadn't had the chance to attend most of the trainings?
Uh-huh.
How we could continue to support them to gain these qualities that support, pretty much support being a part of the community, uh, giving respect, privacy, and dignity to our individuals, and how we could just continue to support that. I just wanted to highlight that.
One of the things that in the governor's May revision of the budget, he had taken out the DSP University. The Department of Developmental Services was looking at trying to make it so that there would be an academic route that providers could go to enhance their skills even more. And the legislature put it back in. So, right now they've passed the budget, but it's really not the final budget. The final budget won't be until probably June 30th. So there's kind of a dance back and forth between the governor's office and the legislature on what they're willing to compromise on, what they can fund, what they can't fund. So whether the state continues to have funds to move ahead with a program to greater professionalize the role of the direct service provider, I guess stay tuned, but hopefully that will be there. Any other questions or concerns? Anybody else want to add anything? Going once? going, going twice? All right. Well, thank you all for your time, and I hope you enjoyed this presentation. And I know I talk fast, and I need to get more humor into these things. But anyways, okay. I'll talk to you all later then. Bye bye.
Thank you, Jeff.
All right. Thank you, Jeff.
Thank you, Jeff.
It's not locking up. Leave session.